As of today, we are reporting 521 cases, 14 deaths, 7 hospitalizations, 3 of those in ICU. Outpatient 322, 178 recovered, giving us a current case fatality rate of 2.7%. Monitoring, we have been monitoring nearly about 800 people total. 531 of those are complete and 240 are still active. So our basically overall case graph looks like this: 521, 178 recovered, 14 deaths, the rest still active. Cumulative case count is looking like this. Remember, this is, you're never going to see that peak. You know, we keep talking about the flatten the curve in the peak. We're looking for this one to plateau and for the slope to start changing. So that's our cumulative case count as of right now. And here's where we are in terms of daily cases by date. I will tell you that yesterday and today, the state has been having problems with their electronic system and reporting out. And so we're going to see a data dump here. Nonetheless, even when we get cases, they actually get put on the day that symptoms began or the day of referral to our system, whichever, if we don't have the date of symptom onset. So what you see reported out in a date oftentimes gets distributed across a number of different dates depending on when symptoms began and when we ultimately end up getting those results. Positive percent per day looks like this in Ingham County, where you see these numbers trending down. And then if you look at a rolling average incidence curve with a percent positive test per day line graph drawn through that, you see basically our trend downwards, as well as that percent positive per day trending downwards. In here, what you would see is a gap that probably has to do with increased testing, and so we have increased numbers, but a lower percent positives per day. Because of some regional work that I do, I have the Clinton, Eaton, and Ingham, Clinton, Eaton counties, Clinton, Eaton, and Ingham counties together in also a 7-day rolling averages of number of cases per day. And then this green line you see through here is that percent positive tests per day. Basically since early April on a downward trend. So testing more, number positive per day, gradually going down. One of the other metrics that I told you that was important to look at is that we are looking at also a downward trend in our hospitalizations. So the green part of that bar is people in ICU, and the blue is people on regular floors, for a total hospitalization number that has been decreasing and then decreasing again this week. By zip code, we're still at 48911 with our highest frequency of cases, and a little bit of an increase from yesterday in 48823 in terms of the case range that they go in. But you didn't see yesterday's chart, so you don't know that. Here is cases by zip code mapped out. So this is flat out case numbers. And then when we take those and put them in a rate, again, taking into account population, 48911 and probably a relatively few number of cases down here in the zip code that is Onondaga Township, but a very low population there, which makes the rate look high. Keep in mind, anytime those numbers are below 20, though I show them to you because rates are always important, it is important that we know that that confidence interval can be quite large. In other words, that's not the data is, we don't have a lot of confidence in that data, but we're showing it anyway. So it's always important to go back and forth between the raw numbers and rates when you have relatively low numbers. By sex, we're still 50-50 in terms of cases, male and female. Our age groups are now 17% in the 30 to 39 and 17% as well in the 50 to 59, and then just 1% lower in the 20 to 29 and 40 to 49. So basically across the board here, 20 through 59 is where we're seeing the highest percent of cases. Again, if you looked at rate, you'd also see that that is probably the highest percent of the population. So lower numbers when you get down into the 80+ age group, and this is a percent graph. So percent cases by race, 50% Caucasian, 25% of African American, 14% Asian, 3% other. And then in a prevalence rate, we see the African American at 406, Asians at 378, other 324, and Caucasians at 120. So at least 3 times for African Americans and Asians the rate of Caucasians for prevalence. Hospitalizations look like this. 99% of our folks are at home right now, just 1% in the hospital. And then when we look at a graph that kind of just shows you the status of all of our cases over time, we are at 34% recovered, 62% at home with mild illness, and then 1% hospitalized and 1% in ICU, with our death rate again just under 3%. Breakdown of the deceased, we're going to start to put this information out there too. Again, when numbers are low, it's a little difficult to go ahead and release a whole lot of information. But we do know that right now our deaths are in the 50 to 59 and up to the 80 plus age range, with 50% of those in the 70 to 79 age group. When we look at sex, they're 57% male and 43% female, and they are 43% African American and 57% Caucasian. And with that, I am going to let my colleague, Renee Kennedy, who was my predecessor here in Ingham County and became the CEO of the Michigan Public Health Institute. I think you all had the opportunity to read or look at her bio in something that Amanda sent out. But I'll also let you know that Renee has long been known as a nationwide expert in health equities, social justice, as it pertains to particularly how it affects our Black population in any number of things. And so right here in Ingham County, one of the leading experts on this, here to talk to you, Dr. Renee Kennedy. Thank you, Renee.
Thank you, Linda. I'm always excited to talk to the media. I was socialized very early in my public health career that the media is your friend. Don't run from them. Answer their questions. So I just want to give some context to the numbers that Linda is sharing with you, and similar trends that we're seeing both in Detroit and, quite candidly, national, and they really are what has contributed to the establishment of 2 really important groups, the Michigan Task Force on Racial Disparity, and also even in our own Ingham County, honored to be a part of the Ingham County Special Populations Committee. So let me start out by just saying to you that race is not a risk factor. There is nothing really scientific, I'll say, about the fact that Blacks and Latinos, people of color, are getting are having higher rates of this particular disease. And let me tell you a little story to explain what I mean when I say that race is not a risk factor. So when even me, as I say, overly educated, college-educated Black woman, I experienced the premature death of my son when he was 6 months old. It wasn't until later, when I became a researcher at Michigan State, that I learned that it is a pattern that college-educated Black women are more likely than white women who do not complete high school to have lose an infant during their first year. So what we began to see was, man, this is not just about economics, because we're much more comfortable talking about economics in this country than we are talking about race. And from a scientific research perspective, we began to say there is a percentage of unexplained variance in what happens in people of color and white Americans that is not just about economics. And we really are ascribing that to this squishy term of institutionalized racism, structural racism. That is a hard word. Yes, it is hard to talk about it, but the solutions are not only personal responsibility, but they're also social responsibility. And so what we realized, even before all of the conversations about racial disparities in COVID, anyone who had been doing work in this space was not at all surprised about that. We were sort of like, when are we going to get to the point that we're seeing people of color are dying more? That even is notwithstanding some of the myths in Black and Brown communities that were saying, oh, Black people aren't getting this, we must be immune. Well, that's not any more legitimate than Black people are getting it, you're more susceptible. And so what we see in this pattern within COVID is really just a representation of the same pattern that we see in infant mortality, that we see in heart disease, that we see in diabetes, other chronic disease measures, because we believe that race is really measuring a social condition and not just a personal characteristic. So one of the things that we're pretty clear about is that the COVID numbers demonstrate to us that inequality and powerlessness makes us sick. When you don't have access to resources to stay healthy, it impacts your ability to assure your own well-being. And one of the things that I would say to you, because this seems so overwhelming, right? How are we going to fix racism? We have an example right here in Ingham County where we know that change happens. In the early 90s, we had a body of elected officials that was very troubled by the fact that many of their constituents did not have access to health care. This is way pre-Obamacare. And there were these people that were falling through the Medicaid crack. They weren't eligible for Medicaid, but they weren't employed. So most of us get our insurance through our employer. And so this body of conscientious and problem-solving minded elected officials said, we want to do something about this. So they didn't just say, why don't these folk work harder to get a job so they have insurance? They said, what is a policy and structural change that we can make to assure health and well-being for our constituents? And so in partnership with Ingham County Health Department, they created the Ingham Health Plan, which was a health benefit. Didn't include inpatient hospitalization, but it did cover prescriptions, doctor's appointments, and things of that nature. So we know that change happens. That Ingham Health Plan actually became sort of the model for a number of county health plans throughout our state. So change happens. It also happens when we think broadly about solutions and not just at that individual. So I think one of the most important partnerships in solving this pandemic, but also other conditions of health and well-being, is for public and the media to see themselves aligned in partnership. And what does that partnership look like? I'll give you just two quick suggestions. One, we really do have to increase our comfort with having this very uncomfortable conversation about race and about racism. We experienced in our state a real demonstration of racialized engagement with the marching on our Capitol. The last one that included people carrying guns, people showing nooses, people displaying swastikas. That is a demonstration of racism. And even when you don't see it, even when if those people argue and say, well, you're being racist, that was a racist demonstration. And so again, getting that conversation outside of I'm pointing to this person as a bad person, and I'm pointing to what is happening in society that's increasing people's likelihood to have such types of demonstrations. But the media helps us have that conversation. And in partnership with public health, we bring some strength to that. The second thing is, how do we reframe the questions that we're asking? I gave you one with the Ingham Health Plan example. Instead of our commissioner saying, why don't these unemployed folk work harder to get a job? They said, what are the things and the structural things that are preventing people from having access to health care? Another simple question, why do people smoke? Well, what are the social structures and pressures that are predisposing people to the stress that causes them to smoke. So how are we changing the narrative together so that we can focus on the collective problem? Personal responsibility is important, and because it's important, social responsibility is also important. So there are lots of things that are introduced to this discussion: implicit bias and institutional racism, but these are all things that are self-perpetuating a pattern that we have to be very intentional together to change. And so the two bodies that I'm honored to serve on, the Michigan Task Force on Coronavirus Disparities, is really just that. It is a time-limited task force. It is designed to end when we lift the emergency status in our state. And so we're working really hard on kind of what are those immediate, we call them kind of downstream solutions. So we're working on accessibility to testing. We're working on what are issues around primary care access that people have. What are issues around their inability to social distance? Are there hotels and other partners that can come along and help people in their need to social distance if they're sick or if they live with people that are particularly vulnerable? So we're focusing there, but we also hope at some point to be able to then deal with some of the systems issues post-COVID that will position Michiganders for better health outcomes. I'm really excited about the work that the Special Populations Committee of Ingham County is also doing, starting with first a strategy around very significant influencers, and we know those to be our faith leaders. We just had a great meeting last week with pastors and reverends in the area. And so again, looking at the both and space, or what are those immediate things we can do, and then as we build relationship and trust in doing those successfully, then it positions us to do longer term work. So I want to thank you, Linda, again for inviting me to speak. I know and I'm convinced that we can come out of this COVID pandemic stronger and better than we went into it, but only if we choose to. It can either strengthen us or it can divide us. And I just think in Ingham County, it's strengthening us.
Thanks, Renee.
All right, now we will open it up for questions. First question is from Dave Ackerley.
Question for Renee. Could have people on the show, right? Because obviously they've been hit harder than we have in mid-Michigan. And one of those segments we talked about the Bagley neighborhood there. I want to address it based on what you were just talking about, with different inequalities, economic, et cetera, because that neighborhood is, it's a cool neighborhood, and it's got 50% of the people, as I was told, living well above the poverty line, and a lot of them making $50,000, $60,000 or more a year, and yet it's been hit about as hard as any in our state in that small area with COVID. What do you attribute that to, and are there gaps in our understanding right now, even involving race, economics, and the virus?
That's a great question, Dave. I am not familiar with the Bagley neighborhood. Is that in Lansing or in Detroit?
In Detroit, west of University, off of Woodward, west northwest in the city. Pretty nice neighborhood, one step down from University, and yet it has been the hotbed in the immediate Detroit area. About 97, 98% African American, but middle class.
Mm-hmm. So sort of that, again, you'd have to, for me, I think it's a great question, and we have to deconstruct what's the story behind the numbers. And so if I were looking at that situation, and I imagine that will come up in our task force discussions, I'd begin to ask questions about what is the context of people's lives. So 50, 60,000 is certainly above the poverty line. Is that working class? What types of jobs are they involved in? Are they plants? Are they closely contained work environments? What is the context of their homes when they get back? So there are some of those, again, that gets outside of who are the individuals making that money, and what is the context that's contributing to overall to that trend. I will absolutely, thank you for educating me. I'm going to do a little digging on the Badgley circumstance, but I do think that anytime we see numbers are representing an individual, and an individual is representing a collective experience, and what might that be?
Thank you.
Next, we have Megan Banta.
Linda, what can you tell us about the person who died from the virus between now and yesterday's update?
That was a woman in her 90s who had been a resident of a long-term care facility where we know that there are cases, who basically she and her husband chose to put her on comfort care and allow her to pass. There were some other issues going on, but certainly the COVID-19 was a significant contributing cause of death relative to oxygen levels and things like that. So,
yeah. Do you know, is she the first in the county to kind of elect to just go on?
No, we've had a number of our cases transition to comfort care. We had one earlier on who was in end-stage renal disease and elected to discontinue dialysis and move to comfort care. So no, it is not the only one. We also had one that had a stroke unrelated to, I mean, I know that we're seeing strokes with COVID-19. I don't think this was related to COVID-19 because it actually happened before the hospitalization. I think it might have even happened before symptom onset, and then came, other symptoms on top of that, which complicated the whole case and eventually moved to comfort care. So no, it's not the only one.
If anyone has a question, go ahead. I don't have any in the queue. Dave Ackerley.
Linda, you mentioned yesterday and today the state's got the 10 a.m. cutoff. You said there were still some issues with the reporting out, or does that mean their software? I checked with them again. They said, oh, we're all good to go. We've been good to go today. Our issues were all corrected yesterday late afternoon, and we're fine. So is any idea what that might be then?
It has to do with electronic reporting out. So it's a matter of basically the data getting pushed out of MDSS into where they collect the data. I'd have to go read my emails again to tell you all the techie terms behind that. But I think you noticed yesterday there were like 100 some cases reported. We knew then that they were not able to pull the data, the complete data set. So we had our numbers, but we didn't have a lot of numbers statewide. And when the numbers came out today, they did say that they're still working on catching up with that data that did not electronically get pushed out yesterday. So that's about all I know about it. It's at the state level. So.
Okay. So you would suspect when you say data dump, normally we've been getting that on Tuesdays, but that maybe this is pushing that further into the week.
Yeah. So the data dump, that's a different data dump. That's a catch up. So what happens is over the weekend, we usually get, I don't know whether it's the laboratory going down to a less staffing to where they're resulting out less test results, which we then catch up with middle of the week. But you've seen this kind of trend for the last, 3 or 4 weeks where we kind of dip down over the weekend and then come back up over the week.
Yeah.
This is yet a different complication on top of that, which literally had to do with the entire state system's ability to electronically report out cases that were in MDSS to the, I can't explain it any better than that without going back to my email. But it might be there's MDSS and there's an OMR. There are a bunch of different data systems that put all of this together, and they were having challenges with one of them. So that is going to be kind of a different kind of catch up. We know that data is there. They just were not able to push it out of the state system.
Okay, thanks.
I have a question from Sarah Lear via chat. It's, Can you say which long-term care facility the death occurred at? Was it a facility with a large outbreak?
I'm not going to really, it's an individual. So any piece of information I release about that is likely to lead to, identifiable information and protected health information. We don't have, I think our outbreaks in Ingham County at long-term care facilities are all relatively small. So we have, 2-3 facilities that have outbreaks. Remember, outbreaks are anything more than 2 cases. The death did not occur at the facility. The death occurred in the hospital. The person had been living at a long-term care facility in the county. And it is one of the ones that we knew we had cases in. And remember, we also have one facility that is actually accepting discharged patients into their, what they call a COVID wing. So.
Thank you. Brittany Flowers, go ahead.
Linda, we had gotten some information that a COVID-19 outbreak at a nursing home near Alma was potentially a result of patients being transferred from Detroit. I know this is outside of Ingham County, but because it's still kind of the mid-Michigan area and cases are going up quickly there, I just wanted to see if this is something that you've heard about or know anything about.
The state has created regional hubs, regional nursing home hubs, to help with some of the discharged patients, because we do run into some cases or instances where nursing homes or long-term care facilities have been unwilling to take discharged patients back in. We've been fortunate that we haven't had that problem here, but there are regional hubs. So I would expect that is probably related to the regional hubs, but I don't really know what facility in that area was identified as a regional hub. We are part of, for public health purposes, we're part of Region 1, and the regional hub is actually in Livingston County for this area.